Okay. Now, we discussed last week the molecular aspects of the heart failure. We went a little bit through the anatomy and the functional aspects of the heart. And today I will focus on the changes that happen at the molecular level in a failing heart. And we will look into how we can intervene and what are the strategies we follow to find new therapeutics for heart failure. Again, office hours as usual. Come to office hours whenever you need. And there is this reminder for every one of you guys that please go and evaluate this course. And my general recommendation for every one of you is to evaluate every single course you take. It's very important. It's a good feedback to the professors. It's good feedback for the department. And it's a good practice that could enhance the level of the teaching and learning and the experience between professors and students. So I highly recommend that you go again. There's 2 more days. I saw that it's only like 14% that answered the question. So please go and evaluate the course. So
Sorry to
today,
interrupt, Professor, but like we can't see your slides.
okay, you. Thank you for noting. Sharing that. So yeah, what I was saying is that please, I put a slide here, go to that link and evaluate the course. It takes you maybe a minute or two, but it's very important for professors, students, and department. So we kind of touched on the molecular basis or the physiological manifestations in general, what causes a myocardial infarction or an increase in the pressure or atherosclerosis or arrhythmia, without going too much into the anatomy and the system biology between different organs. Although this is a very, very complicated thing, particularly when you are studying the heart, it is a connected organ to the brain, to the blood, vascular system, uh, to the kidney, to the lungs. So all that is connected. So it's really very, very difficult to affect one of the organs without touching on the other. And that's why I wanted to go on another lecture on this. First, because I'm fascinated with the heart. And second, because the applications you can see here is a snapshot of how would you think in terms of therapeutics from the molecular aspects, and how could you use those, what you learn from these genes and proteins in order to consider how you make drug uh, generation. And it shows you how complicated that would be. So also in this class, we will discuss few things that you hear in the clinic, although it's not really our intention to go to discuss the clinical aspect of that. But these are general stuff that happen, and you hear that they did this test and they got this much of increase or stuff like that. So it's important for us to just have a look. And this slide is presented in the beginning of the class and in the end of the class because it kind of summarizes the myocyte death or the cardiac myocyte death. Okay. And remember, cardiac myocytes, these are the contractile units in the heart. And those are the ones that are really limited and they are not regenerative. Therefore, if a adult cardiomyocyte die, it has to be replaced. And the replacement, most of the time, happens by activation of fibroblasts, and this causes the fibrotic response to take place. Okay. I can make this smaller. Okay. So necrosis, it's one of the cell death pathways that we didn't really describe extensively in the previous classes. But in cardiomyocytes, because the induction of uh, cardiomyocyte death is mostly affected by the level of oxygen, and since the blood flow that is nourishing the heart muscle is vulnerable to what we have seen in previous classes, like sudden arrest in the blood flow, and that's what causes ischemia. So there's a loss of the oxygen that is being delivered to that tissue. And then even if we reperfuse that tissue, reperfusion means to recover the flow, and therefore the oxygen is back and the nutrients are back, then the damage is going to induce cardiomyocyte death. And most of the times, the cardiomyocyte death is through the necrotic pathway. And today's lecture, I intended to show you this slide because you can see that there are multiple steps and there are more steps coming here. But we described every single step of those in a separate class. And it happens that with cardiomyocyte necrosis, we have most of that just co-localized and drives the necrotic pathway. So let's read quickly through this. Ischemia means the loss of the oxygen. It will cause ATP depletion, right? Because you don't have enough oxygen. The moment you don't have enough oxygen, you don't have oxidative phosphorylation. ATP is low, then the channels that need ATP, the ATPase, sodium, potassium pump, H plus pump, calcium pump, all those will start failing. Okay. These two fail, you start increasing sodium, the protons, and calcium. But then there's one more factor that, okay, now we have those components are getting high. But the initial inducer here is that we don't have oxygen, we don't have ATP, and therefore the cell has to find a different way to get energy. So anaerobic glycolysis start to work. And therefore, if you remember anaerobic glycolysis, it produces less energy and it produces lactic acid, and therefore more H plus is being induced. More sodium being accumulated in the cell. And the notion that you have more sodium or more calcium or more potassium, most of the time is followed by the water rushing into that cell, and therefore there will be an osmotic imbalance. Now you accumulated sodium so much to the level that the sodium calcium exchanger reverses its function. Normally it exports calcium in exchange to the sodium, right? But now we already have lots of sodium inside the cell, which forces to import calcium instead. And therefore, the levels of calcium start to become higher. I don't have to tell you what happens when calcium increases because you already got it and you answered the question. It affects many proteins. It affects the mitochondria. It induces reactive oxygen species. And the reactive oxygen species mainly increase with the reperfusion because there was a sudden loss of the oxygen, and then there is a rush of the oxygen. And when the rush of the oxygen is back, it's in a situation that some damage that happened. Damage is explained by 1, 2, 3, 4. and therefore there is more reactive oxygen species being generated. Well, all that, you already have two levels of effects on mitochondria. There's increased calcium, and there's activation of those enzymes, and there's reactive oxygen species, which start to affect the mitochondrial integrity itself. So the mitochondrial permeability pore opens, and now you lose the integrity of the mitochondria itself. So loss of the mitochondrial membrane, and therefore stopping to generate ATP completely. Now you had depletion to start with. Here you start to block to zero. So almost no generation of ATP. So the cycle is going to become more pronounced from 1 to 6. Then this means the integrity is lost, and therefore the water could rush into the mitochondria, and the rupture will take place. And that's when pro-necrotic factors start to build. This is the first sign for the necrosis to be like it's a one-way ticket from this point. Okay. The loss of the mitochondrial integrity, it also affects the cytoplasmic acidity. And the cytoplasmic acidity is directly correlated to lysosomal activity. The more acidic, the more unstable are those lysosomes. And then those lysosomes will become, they are less stable. Therefore, they could start activating the breakdown of the cell. There's an example here for you. So acidic pH activate lysosomal hydrolases, like a protein called cathepsin. This is a group of them. So the lysosome grows and leads to the rupture. And again, remember that necrosis is not a well-organized process. It's happening passively. And therefore, at a certain point, the cell is going to rupture and all the components of the cell are going to be released. So this is at step 9, where you have the water influx and then the rupture of those hydrolases. And those hydrolases will complete the process of dismantling the cell. And therefore, at this point, it's the irreversible death of the cells. So overall, these steps is describing only one pathway. And it could be happening in cardiomyocyte, but now cardiomyocyte are the most vulnerable because they have to contract every single second. This process happened in multiple tissues, so it can apply the same way in multiple tissues. But the trigger could be different, and the magnitude of that trigger could be different. Like loss of ATP could be detrimental for cardiomyocytes that cannot be recovered, but other cells could survive it more. And the other issue, think about the tissue you are talking about. That heart is not regenerative, but for example, skin is regenerative. So if some skin cells die, the effect is not going to be the same on those two tissues. Okay, so I will come back after today's lecture to this slide again to describe a little bit more how our understanding changed when we look to the molecular aspects that we are describing today. So in the last class, we discussed the process of necrosis. So that's why I wanted to make sure that you guys know exactly what's happening, because it's very, how to say, short descriptive in the previous classes. But again, it's important to know what is the trigger and what is the target. So in this condition here, we were describing that anoxia and oxygen, we don't have any flow of that blood beyond this thrombus. So that's the situation we were describing. And even if you do the reperfusion, the cell will go to the necrosis. Most of the cells will necrote and will die by the process that I just described. So no matter what is the trigger, the steps that lead to the necrotic cell could be like a cascade that is different. And we described atherosclerosis being one of those, because with atherosclerosis, there are other factors that are playing a role. So remember that there are multiple steps for this process, but the end point is that with the atherosclerosis, you will get this complicated lesion that affect blood flow. And therefore, the final outcome is that less nutrient, less oxygen, less blood is flowing into that organ. And therefore, the outcome of that is the death of the cell. Okay, so I'm not going to go back for this. Now I will go to the myocardial infarction. So if a blockade happens in the coronary arteries, which are the arteries that nourish the muscle of the heart itself with the oxygen and nutrient, this happens as an acute injury because it's sudden, and it's mostly caused by an extended obstruction, like a blood clot or other causes of inflammatory responses that could really block the blood from flowing in the coronary arteries. And it could be resulting from these atherosclerotic plugs that are circulating in the blood. So once these are free and then they are with flying with this circulation, then it reaches to the coronary artery and block one of these arteries. And then we spoke about that this could make electrocardiogram changes, and particularly T-wave ischemia inversion and ST segment changes, or ST elevated myocardial infarction. So what that tells you, yes, those changes, we could detect them quickly with the ECG, because ischemia 90% of the time is associated with the T-wave inversion. And the changes in the ST segment are really indications of a myocardial infarction that took place. And that's why, if you look from the clinical side, they would call the myocardial infarction as STEMI or non-STEMI. If there is a STEMI means there's a change in the ST segment, or non-STEMI, this means there's no changes. Okay, and that indicates for the clinicians what type of other tests they should need to do, and they should directly look to other markers once they get into one of these two situations. And most of the biomarkers that we use, I'm sure probably you have heard about those, would be troponin I and the creatine kinase and the lactate dehydrogenase. And these are three very famous biomarkers that we use to check the process of damage in the cardiac muscle. Now, this is an ECG of a normal heart, and that's an ischemic heart. And you can see the depolarization here is totally different from that. And if there's a myocardial injury that took place, you can see the change either in this situation or in that situation. Both could tell that there's a change in the ST segment and therefore more clinical analysis should be taking place. Now, in conditions of STEMI, the first thing is to be done is the tissue plasminogen activator, which is a natural fibrinolytic protein. So this is like a test. It's an intervention, if you want to say, to break down the blood clots. Because once something like this happens, the first indication you get is that the coronary artery is clogged. And therefore, you don't want this situation to become more drastic. And therefore, you would need these group of enzymes to be present. For those who will follow up and go to the pharmacology classes and to the types of the drugs being used, these are known groups of medications that usually are used even after the myocardial infarction to make sure that any blood clots in the circulation are being dissolved. But now let's focus on some of the aspects that we could see at the molecular level. Now, one other thing in the clinics, if the ECG indicates this, we have also other means which we could get the angiograms. The angiograms are, in fact, a snapshot for the blood vessels. And you can see that here, this is a normal baseline artery. And in this patient here, you can see that there's no flow beyond that point. So this is a good indication to localize where the blood clot is being in the coronary artery, and we could also check that after using certain medicaments, it went back to a good flow. So after breaking down these clots. Last year, I had a question about the changes of the electrocardiogram and how can you tell this person has this type of myocardial infarction. So, and this is now being repeated in 2-3 different slides. So be careful and study it very well. That yes, I can show you this and that, and I can tell you, interpret the difference between the two. Now, we're going to go back and describe the serum biomarkers. Now, the serum biomarkers, the first one is the troponin I, and normally this is a cytoskeleton protein that when it's released in the blood, it's a good indication that there is something happening in the muscle of the heart. The second aspect is the creatine kinase, and the creatine kinase is even more important. Well, they are both important, but the creatine kinase can give us a much broader point of view. And why is that? Because when the heart, under normal conditions, it should take whatever glucose and fatty acids and generate the energy. And the heart is a very particular organ because it has to beat every single minute. So it has to have a reserve of energy available all the time. Now, there's nothing new in this slide. It's just a different representation. Well, glucose and glycolysis, and then the pyruvate generation. And then you got the question here already, MPC. And then you have the fatty acid, and then the generation of the acetyl-CoA, and then transportation of that, and then generation of acetyl-CoA, and then the TCA cycle. We already discussed this extensively. Lactates could be used to generate pyruvate. We also mentioned that before. And there are also other forms that we didn't really describe much. I have it in the text for you, like ketones could be also used to generate acetyl-CoA. Now, the most important aspect in this slide is to tell you that the heart really relies on fatty acids to generate energy. Like it's 60 to 90% of the heart energy comes from the fatty acid oxidation. And only 10 to 40% depends on the age and depends on the availability, uh, comes from glycolysis. So there is a good reason why the heart doesn't want to use these glucose as the primary source, because definitely the fatty acid gives more energy because you have a longer side chains. And bearing in mind that we are not really covering how proteins and ketones generate ATP, but they are also considerable amount of energy that the heart uses. Okay, what is the endpoint of generating energy is, in principle, generating the NADH, right? And generating ATP. So what happens next? Next is generation of ATP. So we got the nutrients back here, whatever type of nutrient, we mostly depend on this guy, less dependent on this guy, and much less dependent on those. And now we generated ATP. But then the next step is to really shuttle that ATP into the right site in the heart. And that depends on the creatine kinase system. And here is a link between the heart physiology, the heart metabolism, and it could be a snapshot in case the heart is getting sick, that we could look at the creatine kinase system. And it's not a surprise that the creatine kinase is one of the markers that we look at in case of heart failure. So once that ATP is generated, the final step of cardiac energy metabolism involves what? The shuttling of that ATP into the regions of the high ATP demand, which means the cardiomyocytes. The link between that energy production and the energy utilization is mainly provided by this creatine kinase system. In other words, the cardiac muscles and the muscles in general, they need tons of energy. So they need that reserve to be available so close. So they found this system, which is the creatine kinase system, so that they could store energy in a format that is different from ATP. And the format is the muscle stores creatine phosphate. So creatine that is phosphorylated, a high energy molecule that is locally available for those cardiomyocytes. How does it work? So you have the ATP, and that ATP, in the presence of the protein creatine, it will utilize one phosphate from that ATP, so it will become creatine phosphate. And the ATP, because it loses one phosphate, it becomes the ADP. So the enzyme that performs this function is the creatine kinase. So it switches that phosphatic group from the ATP into creatine to generate creatine phosphate. And now the ATP becomes less energetic. And since creatine kinase is in the vicinity of these cardiomyocytes, then whenever these cardiomyocytes need the energy, it will quickly utilize the phosphatic group. So when ATP levels drop during the contraction, the enzyme creatine kinase rapidly transfers the phosphate from the creatine kinase back to ADP. Okay, so then it will automatically take this phosphatic group and bring it back to the ADP. So you regenerate the ATP. And therefore, the creatine kinase with a less energetic form ADP in conditions of ATP need or contraction. It will regenerate back this fully active molecule that we need for the contraction process and the active myosin binding, and the energy will be there. So this provides a very quick, immediate response where the energy supply locally in that cell. Now, when there is a damage, the creatine kinase levels become very high. And when the creatine kinase is very high and the cardiomyocyte die by necrosis that we just explained in the first couple of slides, then the creatine kinase will be circulating in the blood. And therefore, if there is a myocardial infarction and few cardiomyocytes die, then the clinicians and the doctors in the hospital will directly take some blood and look, do we really have the creatine kinase in the blood? And that would be a good indication that the creatine kinase is released from dead cardiomyocytes and therefore a damage is taking place in the heart. Okay, there's more that can be added to this because it could relate to the contractility of the vessels, it could relate to the contractility of the heart, and it could relate to the activity of the kidneys that I'm not really going to go into more details because we don't have time to do that. But all that is related at certain point to affect the blood pressure. So I will describe a little bit about the RAS system and blood pressure because this is something is important for you to know. But that's how much I will go about creatine kinase. Now, creatine kinase leaks into the blood from the damaged cell, as I said, and it's elevated in the serum. Bear in mind that there are few forms of the creatine kinase. There is a skeletal muscle form, there's a cardiac muscle specific, and there's a brain specific form. So when we look for damage in the heart, we want to make sure we are looking for cardiac damage, so the cardiomyocyte specific one. And that could tell us there's a myocardial infarction taking place, or there's an inflammation that is taking place, and there is some sort of effect that has happened with the heart, such as the heart has gone into lots of these cardioversions, electric shocks, and that affected the heart. Okay, so the point is, this is how you could relay molecular aspects to the functional aspect of the heart. And then you could use those as markers to check the healthiness or the injury of the heart muscle. This is just a summary for what I just told you before, but there is one more information you have to remember, that when the heart becomes injured, although the metabolic activity in the heart is mainly depending on the fatty acid, there are a few things that happen at the molecular levels that it changes the metabolic activity in the heart. And particularly speaking, during the progression of this heart failure, there become a more usage of the glycolysis, which was 10 to 40% in the previous slide, 30 to 40% from other references, so maximum 40%. This becomes more prominent as a source of energy, while the fatty acid oxidation start to become less the dominant source of energy. So this is another indication that we could test that if the heart is moving toward a more glycolysis format compared to the fatty acid oxidation, this is a good sign that the heart failure is progressing. Okay, now bear in mind that we always describe those as a snapshot. It doesn't necessarily mean that it's not really adaptive. It could be an adaptive response. But for acute responses, it could be adaptive, but for long and chronic processes, this initial adaptive process becomes detrimental. Excuse me. And that could be initial steps for a long-term contractile dysfunction and remodeling. Excuse me. Now add more factors into this process. Like describe, you can imagine how it looks like for someone with type 2 diabetes with complication that affected the heart muscle, such as myocardial infarction, or someone who had a chronic inflammation. So the processes become much more complicated, and the drugs to be used for those conditions will become more selected. So what do we do in case of coronary artery disease? One of the possibilities is to have those stents, which means you are introducing a catheter that if the heart was blocked at this level of the coronary artery, that catheter will maintain the vessel open, and if there was a collapse or a blockage, it will allow the blood flow back. And this would be the first level of intervention. The second level would be that you do a bypass, and that is a much more complicated surgery to be done. So you bypass the site of the blockage from an artery. And this is described for you here, which artery does what. And again, this is mostly clinical. We're not going to go to that clinical part too much. In extreme cases, when the heart fails and it's not able to pump and the cardiac output is really low, uh, the next level of intervention would be transplantation. And you know that transplantation is not easy because you need a donor, and that's a very, very long list to wait for a donation. First, because the donors' numbers are very low. Second, because of the autoimmune responses after the transplantation of the heart. And therefore, nowadays, we have what we call left ventricular assist devices, which in principle is a pump that is inserted in the left ventricle, as you can see here. And it will take the function of the heart by pumping the blood from the left ventricle all the way to aorta. And patients could stay on this up to 5 years with minimal issues. Later on, other issues start to happen, and most of the time, those people on left ventricular assist device will be waiting for a heart transplantation. So they could wait a few months, they could wait a couple of years, they could wait 3 years, and sometimes the left ventricular assist devices has to be replaced by another one, which requires another surgery. So now I want to move to discuss about the RAS system and how that controls blood pressure. Now it's funny, I don't know where to start in this slide, up or down, because it could be either way. Because if ventricular remodeling is taking place, or myocardial infarction has started, or a damage in the cardiomyocytes, or a loss in the number of the cardiomyocytes, these cardiomyocytes start to be remodeled, right? And the remodeling process, once it started, depending on the stress, it could be like how it's called reversible. But if the stress continues, that will be irreversible. So in this situation here, we have four major causes of myocardial dysfunction that are listed. Myocardial infarction, we just described it. Ischemia, which could be a cause of the myocardial infarction. Hypertension, which means an induction of or elevation in the blood pressure. So what would that cause? So the heart failure is associated with what? With neurohumoral and metabolic changes. we already described changes in the metabolic activity. One might ask why the heart is going to depend on glucose more. Because one of the types of the stresses that we see is that the heart starts to beat faster. And this is already a stress. If you are beating 70 per minute beats per minute is not the same if you are beating 60 beats per minute. And that's why probably the heart required more energy, and that energy now comes from the switching to the glycolysis. This also needs biochemical changes in the cytoskeleton of the cardiomyocytes. But mitochondrial dysfunction and reduced ATP is a very well known aspect. And probably that's the one we described in the necrotic cell death. But also, when there is a lack in the function of the heart, the output is low, the brain is going to detect that and is going to send signal to the heart to increase the blood pressure. Or in other words, make availability of that circulation higher. And the way it does that is through the activation of the renin-angiotensin system. Renin-angiotensin-aldosterone system. So the R, renin, angiotensin, A, aldosterone, A. Also, there will be an effect on the endothelin and the endothelial system. And finally, a switch in the fatty acid metabolism toward the glucose. Now, in this slide, I want to focus mainly on these three hormones, the angiotensin 2, the aldosterone, and the catecholamine that are epinephrine and norepinephrine. And why I'm describing those for you, because these are the ones that we mostly try to change in order to recover the cardiac function and lower blood pressure. So how does that happen? Cardiac function is becoming lower, output is becoming lower because whatever reason is mentioned here. So cardiac output is low. And when the cardiac output is low, the first thing we detect is a drop in the blood pressure because the heart is not beating enough or not pumping blood enough, or the volume of the blood being circulated is low. Next is that those baroreceptors, the baroreceptors, these are receptors on the blood vessels and on the heart that could detect the changes in the pressure in the left ventricle, in the aorta, and in the vessels. And therefore, these call the brain to activate the release of the catecholamine, the epinephrine and the nephrine, the norepinephrine, these two components. What does that do? These will cause vasoconstriction. In other words, you are trying to increase the blood pressure. You are trying to increase the blood pressure. To understand this notion, imagine you have a balloon and it contains 3 liters of blood. And then you squeeze that balloon. That's the vasoconstriction. The pressure that you get over the balloon becomes higher. And that's exactly what happens here. You constrict the vessels if you have 3 liters of blood, normally 5 to 6, 5 liters of blood. If you squeeze over the blood vessels, the blood pressure that comes from that blood is becoming higher. So the vasoconstriction increases blood pressure, and it also forces the heart to beat more. causes the beats to become higher. Okay. And here it comes to the show, the angiotensin-renin aldosterone system, which is also induced because when the blood pressure is low, kidney could detect that. Because remember, the kidney is the one responsible for filtering the blood. And if the kidney is getting a lower blood pressure, it could activate the protein renin. Renin is activated. And now this is the nodal point to turn on the RAS system. So if I go to the next slide, I wrote down this extensively for you. Renin is released. So we have now a situation where the blood pressure is low. Then renin is detected, this is detected in the kidneys, and it releases renin. Renin, it acts over angiotensinogen, which is produced mainly in the liver, to become angiotensin 1. And then angiotensin 1, as it circulates to the lungs, it is converted by angiotensin converting enzyme, which is called ACE. Most of the time you hear about it, ACE. It becomes angiotensin 2. Now, angiotensin 2 has two effects. First, it increases blood pressure, so you are counteracting this condition. Angiotensin could affect the adrenal gland to generate more aldosterone. And aldosterone asks the kidney to retain more sodium in the blood. And again, when you have more sodium in the blood, more water will go to that blood. And this is why people with high blood pressure are meant to eat diets without sodium, because the increased sodium is going to rush into the bloodstream. Water is going to follow that sodium into the bloodstream. It will increase the volume of the blood, and that will increase the blood pressure. And this will be fluctuating a lot. And therefore, aldosterone uses this technique to ask the kidney to retain more sodium in the blood, so the kidney can take out more sodium to the urine or can keep it in the blood, so it retains more in the blood, and therefore the water rushes into the blood and the blood pressure goes back to normal. Okay, there's other things. So if I go back now, so that drop in the blood pressure is detected by the kidney. The kidney is going to generate renin. Renin is going to affect the angiotensinogen that is generated in the liver to become angiotensin, that when it's circulating and reach the lung by the angiotensin converting enzyme, ACE, it becomes an angiotensin 2, and angiotensin 2, it affects release of more aldosterone, therefore more sodium retention, and it also can affect directly the blood vessel so that it could constrict it and increase the blood pressure and the rate. This is one snapshot of systemic communication that could start in the heart muscle that affects the cardiac outcome and elaborate between the nervous system, kidney, liver, lung, all that to cause the blood pressure to be restored, which gives us like a more complicated picture of what to do to restore heart function by drugs. And trust me, playing with drugs in terms of trials and error is like a big deal. But the changes in the hormone is a much, much complicated step because you could tell that this hormone is affected by that, and this hormone is affected by that, and this hormone is affected by blood pressure. So if you shift the balance of one of these hormones, you are going to have multiple feedback mechanisms that could lead to detrimental effects. So really hormonal changes that I just described for you gives you a snapshot of how complicated are the feedback mechanisms that could affect hormonal generation and the change of the cardiac function, at least here. And for the angiotensin 2, this is the golden hormone in this system. Once it's activated, I listed for you what I just said and how it could lead to the decrease of the blood pressure. We mentioned about the uh, sodium. We mentioned about triggering the aldosterone. And the third thing that I didn't mention is the release of the antidiuretic hormone ADH. It stimulates the release of the antidiuretic hormone, the ADH or vasopressin. So this promotes water reabsorption by the kidney. So at certain point, this also affects the water reabsorption by another intermediate. Okay, but if we have this system in place, we are just trying to raise blood pressure, right? We should have a system in place to counteract that. And that's what we have through the natriuretic peptides. So whenever there is a hormonal effect that causes an induction in the aldosterone and the renin-angiotensin system that causes the vasoconstriction, this is increasing the blood pressure. Okay? To counteract that, the heart has from the right atrium and from the rest of the ventricles these atrial natriuretic peptides, ANP. These are hormones that are normally secreted from the right atrium when right atrial blood pressure increases. So when you have a lot of blood pressure, it raised more than normal, these guys are released. So this will counteract the RAS system in order to decrease the blood pressure. So it's opposite to the function of the RAS system, okay? The natriuretic peptides antagonize the mechanism by promoting what? Promoting water loss and sodium loss. And thus, it promotes the decrease of the total plasma volume. Okay, so these two systems are opposite to each other, which confirms what I just told you about how complicated these hormones are. And which brings us to the treatments that we use. One of the treatments that we could use is that, of course, non-pharmacological is to have healthy diet, exercise, and don't drink fluids that you don't know what is in, like all what we see in the markets with these colors that you have no idea what they do. The sodas with tons of sugars and sodiums inside that those people who are selling you those, they just care for their money, not for your health. The pharmacological parts would be if the pressure is high, we could use diuretics so that this decreases the blood volume. We could use the ACE, the angiotensin converting enzyme inhibitors. So you block the generation of angiotensin. So you don't have the ACE, and therefore you don't have angiotensin, and therefore you don't have higher blood pressure. So you block angiotensin signaling. If the pressure is high, you could use vasodilator. So you make opposite to what you have there. Now here you have vasoconstriction. So if you block angiotensin, you will have no vasoconstriction. Or on the other side, you can work on the vessel itself and use vasodilators. And the part that I will bring you at to discuss is the beta blockers, which blocks epinephrine and norepinephrine. There will be a couple of slides about that. Now, remind you, where are epinephrine and norepinephrine? This is when the brain sends these catecholamines. These are catecholamines, epinephrine and norepinephrine, and normally those cause vasoconstriction. So if you block these, the vasoconstriction is not going to take place. And many times in the heart, you have to have a combination of multiple things. So this slide here shows you that affecting the angiotensins could be blocked, and therefore we could recover the blood pressure back to the normal. Obviously, there's a very complicated signaling pathway, but I think it's already very complicated for you at this point. So let's talk a few words about the beta blockers. And beta blockers, as their name indicates, as if they are very complicated. However, we already have discussed their molecular signature. The beta blockers are beta adrenoreceptors. And these proteins, they have multiple beta isoforms, beta 1, 2, and 3. Beta 1 and 2 are the most expressed in the heart. And when these are activated, they need a signal from the sympathetic nerve or from catecholamines that are circulating around the blood vessels or the heart. So either or, epinephrine or norepinephrine, both of them will activate the beta adrenoreceptor. Now, the chronic stimulation of that, it can cause increase of the heart rate, increase of contractility, and conduction velocity. So these receptors are coupled by G proteins. Recall the signaling molecules we discussed before, the G proteins. There are multiple types of G proteins. This is the G proteins. When they got activated, they leads to the activation of the adenylyl cyclase, and then that forms the cyclic AMP. You got this question in your quiz. What's the downstream target of the G protein? So those receptors bind to the G protein, causes the generation of the cyclic AMP, which is the main signaling molecule by the conversion from an ATP with the enzyme adenylyl cyclase. This molecule induces increase in the heart rate, so you are beating more, increased contractility, so there's more contraction, and there's more conduction velocity. And therefore, if the signaling continue in a stressed heart, that is a source of heart failure cause and under chronic situations. So what is the downstream targets of the cyclic AMP? It will phosphorylate the L-type calcium channel. Again, calcium come back to the show. Increased calcium. And then dephosphorylation of the protein kinase A includes multiple downstream signal. I wrote some of them for you down. For example, cardiac troponin is one of them. Ryanodine receptor, L-type calcium channels, myosin binding protein. All that in the presence of the high calcium will lead to the hyperactivation and the stress that we just discussed in many of the slides before. And therefore, this cardiac muscle now is under stress that could lead to its death by necrosis or an increased hypertrophy could be probably the first start point. Now, I'm sure you will ask, should we memorize those? Probably some of them, particularly cardiac troponin and the renin receptor. And this is just describing for you that drugs that we have is to block the binding of the norepinephrine or epinephrine to the receptors. So the beta blockers that you hear in the clinic are in principle blocking the binding, and therefore the beta 1 and beta 2 are not going to are not going to signal through the adenine acetylase. There will be no cyclic AMP, and therefore all those effects are downregulated and the heart go back to normal. Okay, which brings us to kind of summary of all what we have discussed so far about the heart. I mean, no matter what are the triggers, you name it, hypertension, valvular diseases, ischemia, infarction, myocarditis, infection, mutations, this will cause cellular and molecular changes that we just described and could be sensed by different systems such as the RAS, sympathetic, parasympathetic. Of course, the first step would be adaptation, like in the hypertrophic response and in the fibrotic response, but it could get to a level where apoptosis, necrosis, and autophagy imbalance take place. When these cellular and molecular changes happen, it will cause the structural remodeling of the muscle itself. So the left ventricle becomes dilated or thickened, depending on the cause. The chambers of the heart will become different. The wall stress will become different. So that's a structural remodeling. And then, of course, that is related to a functional consequence where you will have less pressure during the contraction or impaired relaxation. And with this cycle, that's where we can evaluate if we need therapeutic intervention or not. So it's all like kind of connected. Few words about necrosis. I already described it in the first slide, and I said I will come back to this by the end of the lecture. And here you can focus on, this is a cardiomyocyte, and it's under ischemia reperfusion, and it's focusing on two compartments. The mitochondria, which I'm not going to describe anymore because we did this multiple times. And the second part is lysosomes, which normally degrade cellular organelles and recycle them. But now the effect of calcium load, increase of reactive oxygen species, and the H plus acidity, it will induce proteases in the lysosome. And that would induce autophagy, which is in principle one of the processes that happen in the cell normally to recycle those nutrients, proteins, and cellular organs and molecules, which we could detect under effects such as loss of a nutrient. The cell thinks that now it's better to recycle some of the organelles. And if this is prolonged, probably the cell will take a decision to commit suicide after. So autophagic signal mostly relates to loss of a nutrient, loss of oxygen, which brings us to the main discussion that we started. Oh, in myocardial infarction, there's loss of oxygen and loss of nutrients. So some cells will detect that. And how do cells detect that? The famous mTOR and AMPK. So remember these very well. mTOR and AMP activated kinase, AMPK. This we discussed before under the PI3 kinase pathway. Whenever there's a starvation situation, these two will detect the level of the nutrient and will be very conservative about the level of the nutrient in the cell, and then would initiate the process of 4 or 5 different steps where the autophagy response starts by generating of those vacuoles and the uh, fusion of those vacuoles with lysosomes to become degraded. Now, this is one of the forms of the cell death that happen also in the cardiomyocytes, particularly because in conditions of loss of the blood flow, there will be definitely a starvation that is taking place. And just to remind you about autophagy, remember, mTOR normally blocks autophagy. Okay? mTOR normally blocks autophagy because mTOR activates the process of growth. But if mTOR detects through AMPK, it's not in this slide, it's in the slide that we described under the PI3 kinase, then the process of the synthesis will be blocked. And therefore, if you block mTOR, this will be activated. Autophagy will be activated. Now, the proteins that perform this function are called autophagy-related protein, and they are mentioned as ATG. The most important and the first in the cascade are the ATG5 and the backlin. These are needed to be the assembly for the start of the autophagic pathway. Okay, I just wanted to remind you that, yes, we're mentioning that necrosis, autophagy, apoptosis, this might happen all together, depending on the cause, depending on the localization of these cardiomyocytes or other cells. Which brings us back to that initial slide. I hope now it gives you more input about the condition of increased acidosis and how that is related to the lysosome and autophagic response. And this would be the last slide. Next class, I will have very few slides, maybe 5, 6 slides. I'm not sure yet, but I will be describing for you a few aspects about the muscle injury and how can we correct that by CRISPR-Cas9. It's a very important notion you guys need, and it's one of the fashion these days that probably goes to clinic soon. With this, I thank you for your attention. If you guys have any questions, let me know. Questions? Anything need to be recovered? All good? Okay, I'm gonna stop sharing. All good. I'm gonna stop